Today, I'm the Chief Philanthropy Officer here at Providence. And as a reminder, before we kick off this conversation today, the information provided during this event is for educational purposes only. It is not intended, nor is it implied to be a substitute for professional medical advice. Even today, when we are talking with a doctor, always consult with your personal healthcare provider to determine the appropriateness of the information for your own situation. If you have any questions regarding medical conditions or treatment plans, please consult your physician. Participating in this event with this clinician does not create a physician-patient relationship. So now let's begin. And I'm really excited today because I'm actually interviewing one of my friends. So usually I'm meeting people for the first time, but today we have Dr. Ty Gluckman, and he is the medical director for the Center for Cardiovascular Analytics, Research, and Data Science, which we commonly refer to as CARDS, and he's at Providence. And he's been doing some incredible work over the summer and way before then too. But Ty, tell us a little bit about your role at Providence before we get started about the topic today.
Thanks, Lori, for having me, and it's a real pleasure to be with you. I'm a cardiologist. I've been with Providence for 15 years. I'm a clinical cardiologist, but over the last couple of years, building up an infrastructure to support what we call investigator-initiated research, allowing our own clinicians to mine our own data and other data sets to be able to help better inform some of the care that we deliver day in and day out. And my focus is in cardiology.
And Ty, you came to us, you've been, before you came to Providence, you were at Northwestern, and then you were at Johns Hopkins. And I know you're really tied in with sort of the global community of doctors doing this kind of work. Is that right?
Yeah, no, I've been fortunate, moved most recently from the East Coast again about 15 years ago. And wear different hats, but I'm very involved with both the American Heart Association, the American College of Cardiology. And my real passion is trying to identify gaps in care and figuring out ways, innovative ways that we can close those gaps.
Right, and Ty is based here at the Providence Heart Institute here in Portland, Oregon, but has a regional role now working with a lot of data throughout the system. And could you talk a little bit about all of the patients that we care for as a system within our 7 states and our 55 hospitals, and how you have access to that kind of data and why that's helpful in your work?
Sure. As many of you may know, we have a large footprint that extends all the way from Alaska down to West Texas. And in each of those different regions, to a large degree, the data flows into a common repository. It's not so simple as that, but the ability to be able to pull the data both from the hospital setting as well as the clinic setting and better understand the care that's being delivered, variation in practice, and where we can learn from a very large data set, so to speak, putting big data to good use, is a lot of the work that I'm and many others are doing as well.
Yeah, and I think that's one thing that we always want to remind people, that the care that we give locally is so excellent, but we also have the access to patient care throughout the 7 states that really drives, our excellence, I think, as we move forward. So today we're going to talk a little bit about this incredible study that you all just did, and you were recently published in the Journal of American Medical Association, Cardiology, for your studies on heart attack patients over the course of the pandemic. So what were some of the major themes you discussed in the article and that you found in going through, COVID and heart disease?
Yeah, thanks for asking me and asking this question. So as many of you that are listening know, one of the concerns in the United States as the pandemic hit was potentially overwhelming our hospitals. Might we not have enough ventilators, ICU beds alone? And so there were executive orders across the United States, as well as local management of how are you going to deal with the pandemic. Many hospitals deferred non-urgent procedures and testing as a result. But one of the early observations, even preceding our work, was a recognition that we were seeing fewer people come to the emergency department, fewer people come to the hospital. And we knew, in fact, that people were having events, heart attacks and strokes. So this was turning to our own data to better learn from that overall. And so what we did is we looked across almost 50 hospitals in our system to ask the question, historically, how many people on a weekly basis were coming in with heart attacks, and what did things look like in the early period of the pandemic and later into the pandemic in terms of not only cases of heart attack, but were these patients that were coming in the midst of the pandemic different? Were they being treated differently, and were their outcomes any different overall?
And so were there a difference in the demographics of the people that you were studying? What did the data tell you?
So surprisingly, the patients were more similar than we would have expected overall. The biggest observation in terms of the demographics were that patients coming in with heart attacks in the midst of the pandemic were about 1 to 3 years younger than they were prior to the pandemic. And we know the fact that age greater than or equal to 65 years is a risk factor for more severe manifestations of COVID-19. And so one of the observations, in fact, or speculations were maybe older individuals were more resistant to come to the hospital overall. Interestingly, the burden of the typical risk factors for a heart attack, high blood pressure, high cholesterol, were no different in people in the pandemic than prior to it. And the treatment approach, medical management, bypass surgery, or stenting, coronary angioplasty, was no different overall. But what we did observe is in late February, beginning at the very end of February, through a period into the very end of March for a period of 5 weeks, a very abrupt drop in the number of people week over week in terms of those coming in with heart attacks, such that from the pre-pandemic period all the way down to the period in late March, we saw a 50% reduction in the weekly number of individuals coming in with heart attack.
And would those be people typically that would come into the emergency room to begin with?
Absolutely. Most of our patients would come in seeking care in the emergency department. The good news is that on the back end of that, beginning in April and moving into mid-May, rates of people coming back into the hospital with heart attacks rose, but it rose about half as fast as it fell. And by the mid-May period, we still hadn't gotten back to our baseline. And so what worries a lot of us is people, probably out of fear of the current pandemic, were avoiding hospitals in spite of having heart attacks and still had not returned back to where things were prior to the pandemic.
So if you were at home, you were afraid to go in, you had a heart attack, you weren't sure, how will you know how will you know what to do next, or should you go see your physician if you had a issue like that, to see if they can do a test to see if you did in fact have a heart attack? I mean, I'm just wondering how many hundreds of thousands of people are walking around that had a heart event and didn't know it.
Yeah, so it's scary across the board from that perspective. What I will say is, and this reinforces the importance of not delaying, is that in our study, we found that early into the pandemic and later on, people who had heart attacks, particularly a type of heart attack called a STEMI, where they have a complete occlusion of their artery of their heart, those individuals had a significant increase in their risk of death while they were in the hospital. And so what it suggested to us is, of people presenting with a heart attack, any delay in seeking medical attention can have severe consequences. So if you're at home, you have chest discomfort, shortness of breath, symptoms that you were concerned about that you've never experienced before, or have experienced and you know they're a reflection of your heart, seek medical attention immediately. Call 911, call emergency medical services. We'd rather have you have a false alarm in the emergency department that gets evaluated. And importantly, our hospitals are safe places for people to come to.
Yeah, I think that's one thing that we keep in all of these discussions. We really want people to know the hospital is one of the safest places you're going to come right now. Everything is, when you go in, they're taking temperatures, they're asking questions, they're masking everyone. So, and I know Providence has put a huge effort toward that. So not very few visitors are coming into the hospital, if any. So it is a safe place to go. So were there any limitations to the study?
Yeah, so anytime you look at large data sets, and there was some urgency for us in getting this data out there, because not only did we learn internally for us, but the learnings have been spread across the globe and have reinforced exactly what we were just discussing. You need to seek medical attention immediately. Our analysis was based upon coding data. So when someone comes to the hospital with a heart attack, there are certain codes that are inserted into the electronic medical record system and allow claims to be placed based on that. And those coded data, is reliant upon the documentation in the medical record, et cetera. It has potential limitations. Number two, this wasn't a randomized study. This is an observational analysis, meaning we're observing the patterns over time. And as a result, because it's not a clinical trial where we're randomizing people to a drug or a device versus standard care, we can't necessarily infer what's called causation, meaning we can identify observations, we can make inferences from that. And I think the inferences are sound that the higher mortality rate are likely related to people delaying care, seeking medical attention late overall. But we can't imply that because there was a higher mortality, it was because of these other things. We also, in our data set, did not specifically reconcile against people having COVID. So is it possible that the population that had higher death rates related to their heart attack might have had concomitant COVID-19 infection? One check and balance in our analysis was there were two main types of heart attack. One is called a STEMI, which is where the heart artery is completely blocked, and another is called a non-STEMI, the other type of heart attack.
Okay.
What we observed is the mortality rate was higher only in that STEMI group, not in the other group. So in order to try and attribute this to COVID, you'd have to say that the COVID infection was only in one type of population with a heart attack, which doesn't make any biologic sense overall. So there are limitations, but the large size of our data set, this was over 15,000 heart attacks involving nearly 15,000 patients. And it highlights the value of larger data sets, big data, in being able to adjust for the limitations of studies like this.
And Ty, that was how many weeks worth of data?
So we went back to the very end of December of 2018 to get an entire 2019 lead time, and then into the first 2 months of February of 2020 to give us a sort of run-in to figure out what were the average or weekly cases that you would see of heart attacks, knowing that there's week-to-week variability. And then we saw this precipitous drop beginning at the very end of February, getting for 5 weeks, and then the rebound beginning at the very end of March. And this has been a replication of what we've seen elsewhere in Italy, in Spain, in the United Kingdom. The timeline is roughly around the same.
And so, you know, trending forward, you looked backwards, you're living through it now. Do you see any predictable trends as we kind of move through this?
So just prior to this, I was on a call with leadership from the American College of Cardiology. And I think one of the key takeaways that have come about from the American College of Cardiology, the American Heart Association, the European Society of Cardiology is do not delay care. Okay. And I think one of the things that we've suffered, and we can beat ourselves up about this, is we didn't know what the pandemic trajectory was going to look like. Very appropriately, we took steps to protect our hospital capacity to not be overwhelmed, and see what happened in Italy, where hospitals were overwhelmed and they couldn't even take care of patients overall. Now that we've moved beyond that, I think if there's a second wave this fall, either in terms of the pandemic itself or challenges in bed capacity because of the flu, influenza season, how do we make sure that we always have open doors, that patients, we always have had open doors, but that our patients don't feel like it's A, not safe, or B, I'm getting mixed messages. And so the most important thing going forward is to be very clear and not have any mixed messages whatsoever, and reinforce hospitals are a safe place. That's where you need to go.
Yeah, absolutely. And what is the relationship, if there is one, between COVID and heart attacks?
Yeah, so we recognize the fact, a couple of things. The virus SARS-CoV-2 that is responsible for the COVID-19 pandemic has affected all aspects of healthcare. It's one of the very unique situations where a communicable disease, an infectious disease, is having a unbelievable, unparalleled effect in non-communicable diseases overall. We do know that individuals that have either cardiovascular risk factors like high blood pressure, diabetes, or people that have pre-existing cardiovascular disease, they've had a heart attack, they've had a stroke, those individuals are at heightened risk for having more severe manifestations of COVID-19. But we also know that there are really three ways in which patients can be affected and their hearts can be affected by people who have COVID-19. One is it can cause direct injury to the heart in a way that might look like a heart attack, but isn't necessarily a heart attack in the traditional sense. It can cause what we call myocardial injury. It can also render people susceptible or at risk for developing heart failure. And there are, again, direct effects or indirect effects by which that can occur. And early reports, particularly out of China, highlighted the fact that arrhythmias or abnormal heart rhythms may occur at a higher rate in people with COVID-19 infection. So there are both direct effects from COVID and then all of the untoward indirect effects by people perhaps not seeking medical attention as well.
Right, right. We do have a question from the audience, and this person is wondering, when's the right time to go to the ER for heart problems, and how do they know if they're having a heart attack?
It's a really challenging issue, and I will say it's a phenomenal question that people often will ask, and in particular, people will ask and say, I had a heart attack once, I know those symptoms, but if, God forbid, they have a heart attack again, the symptoms may not always be the same.
Okay.
So the classic symptoms are chest discomfort, pain, pressure, heaviness, shortness of breath, sweating, or nausea. And I would say if you're worried, if someone's sitting on your shoulder or a voice in the back of your head says something doesn't seem right, that's a clue that something probably isn't right. You need to seek medical attention. I will also just add that women, more commonly than men, will present with less typical symptoms. And so it may be back discomfort, jaw discomfort, neck discomfort, shoulder discomfort. And so if you develop a new symptom, something doesn't seem right, again, we'd rather you seek medical attention immediately, have the appropriate evaluation, and then if it turns out you didn't have a heart attack, sort out what is the cause. And obviously, if you're having a cardiac event, get the appropriate treatment.
And you know, getting back to, thank you for that. I think almost every person that walks around that's an adult thinks they have a chest pain. Oh my gosh, am I having a heart attack? And so I think it's always good to hear from the experts that you're probably not. It's just a little gas or something, but yeah, if you have lingering problems or really something unusual, call your doctor, call 911, go to the emergency room. And so some folks are also wondering, you know, is it safe to go to the emergency room? Are the COVID patients in the emergency room too? In some of our areas within Providence, we're seeing less and less of the coronavirus, thankfully, so the emergency room doesn't have as many, but what's going on in general, as far as you know, across the country with emergency rooms and coronavirus?
I can attest to not only hospitals in the United States, but across the world, as well as certainly those within Providence, have taken great lengths to make the hospitals, both for visitors that are coming in to visit loved ones, but also those seeking medical attention or procedures or tests, and those requiring acute care, the safest place possible. Individuals are getting temperature screening, they're getting questions asked of them. Personal protective equipment is being utilized by our frontline healthcare workers. And this is all not only to protect individuals coming in, but to protect everyone else as well. So obviously no one ever wants to have to go to the hospital if they can avoid it. But I do want to reassure individuals it's a safe place to be. It's the right place to be if there's any concern. Please do not delay seeking medical attention if it's of concern to you.
Thank you for that. One of the things that I've learned a lot from you guys, and just working together as we work with philanthropists that really want to make a difference through the Heart Institute, is all the different ways that your heart can be impacted. We think of the common heart attack, but you talked earlier about heart failure. And can you explain what heart failure is?
Sure. In its simplest term, heart failure seems like a simple concept, but it really is a syndrome. And I say that to say that there's a lot more heterogeneity in the term heart failure. But heart failure is a condition or a syndrome where the heart either doesn't relax normally, it doesn't squeeze normally, or both. And it has a compromise in the heart's ability to eject blood. There are individuals that have few to no symptoms with heart failure, and there are individuals that are very severely impacted and limited by their heart failure overall. And to add to the complexity of this, there are a multitude of different causes of heart failure as well. So if you're someone who's been diagnosed with heart failure in the past, there are symptoms of shortness of breath, weight gain that is associated most commonly with swelling in the legs, swelling in the abdomen, difficulty breathing when you are in bed at night. Those are symptoms that may be suggestive of heart failure, and seeking further attention to figure out not only do I have heart failure, but what may be the underlying cause, and then what is the best treatment to address it.
Okay. Yeah. I just think we often think of lung failure and things like that, but heart failure, brain failure, there's just all your organs are working for you. And so you want to make sure to keep them healthy. And with that, how do we live a better lifestyle, and how do we keep our hearts healthy? I know at Providence, you guys have initiated so many great programs like the FIT Project, Heart to Start. There's the 80% rule that you might explain a little bit to our guests, but how can we live a healthier, heart healthy life?
Yeah, you'll often hear me say my greatest joy in life would be putting myself out of business. And I think this is a reinforcement of prevention. So whether we're talking about coronary artery disease, of which common manifestation is a heart attack, heart failure, some of our most common heart rhythm abnormalities like atrial fibrillation, they all share common underpinnings of the traditional risk factors that we are all trying desperately to eliminate, reduce. These include overweight and obese states. These include high blood pressure, high cholesterol, diabetes. And so when you talk about the basic blocking and tackling, whether you're someone who's already been diagnosed with one of these conditions, or you're trying to take proactive steps to prevent it from ever occurring in the first place, you're someone who has a strong family history, or you're just proactive about your health, it is, and the American Heart Association has something called the Simple Seven. It is avoidance of tobacco. It's losing weight. It's controlling your blood pressure. It's knowing what your cholesterol and blood sugar levels are. It's enrolling in a regular program that may be formally enrolling or doing it at home around exercise and modification of your diet to facilitate a heart healthy lifestyle. These are really the mainstays of all of the things that we know are so important in mitigating, reducing the risk of having a first event, or for someone who's had an event, reducing the risk of that next event.
Great. And I'm always curious, you could have gone into any field of medicine. Clearly, you're a brilliant doctor. Why heart? Why did you choose cardiology as your area of expertise?
Yeah. So someone told me a long time ago, find an area in medicine where the vast majority of the time that you'll be spent, it's taking care of the most common conditions. So fascinated maybe is the wrong choice of words, but I was intrigued by a condition that frankly is the number one killer for men and women alike. Heart disease, it's anybody who's listening either may be personally affected, has a parent, a sibling, a relative who has it. And that's what motivated me, I think, more than anything else. I also was shaped by the fact that it is a field where we have almost more data. And I'm someone who wants more and more data, and we're working to get more and more data. But I would say that unequivocally, we have trials of 10,000, 20,000, 30,000 patients. So a lot of our practice in the field of cardiovascular medicine, cardiology, is informed and shaped by guidelines that rely upon tens of thousands of individuals across the planet being studied. And it's not a matter of often the right thing to do. In many cases, we have the right answer. But we have a wealth of data to help shape what is best practice in the care of our patients today. So it was a combination of the most common conditions, really trying to thwart the number one killer for men and women alike, with a field that's informed by a lot of tremendous science.
And so great to have you with us. And we're learning so much through all this data, and just your passion for it is really inspiring for all of us. And I have one last question for you, and then I'll turn it over to you to kind of close it out. But one of the things I've always wondered is there's so many screenings that when you're age 40, get a mammogram. When you're age 50, get a colonoscopy. When is there an age for when you should get some sort of a heart scan or, a test?
Yeah, it's a great question. And the totality of data would suggest now, in contrast to a colonoscopy, a screening mammogram, we really don't have that in the same sense from a traditional imaging type of test in cardiovascular medicine. We do know that all individuals should have their blood pressure evaluated. They should know what their blood sugars look like. And in fact, the pediatrics, so now going down into childhood, should know what individuals' cholesterol levels look like, because some individuals are born with an inherited predisposition to high cholesterol. So knowing your numbers, and you'll hear that term used a lot, the three key numbers are blood pressure, your cholesterol numbers, and your blood sugar. Additional numbers to know about that is your height and weight, to figure out, is my weight overall ideal for my height? But that's the mainstay. Now, based on those numbers, there may be additional testing that's recommended, even in asymptomatic individuals, to inform whether or not cholesterol lowering therapy is warranted, blood pressure lowering therapy is warranted, and what other steps can be taken to help reduce risk overall. So knowing the basic numbers is of key importance, informs your care provider, but importantly informs you overall.
Great. Good. I know it seems like when you get to a certain age, you think, oh, I need to go in for a certain test to confirm everything's okay. But in general, that's not the case. So, well, is there anything before we close out the hour or the half an hour that you'd like to share with people at home?
I just want to thank everybody for the opportunity here. I do want to say that this is tremendously scary times. And for many of us who now since February have been dealing with being overwhelmed, whether it's being socially distanced from family members, friends, not having life as usual, we still do not have a vaccine for this virus. And we do not have an imminent time of when that vaccine will be available. So from a public health infection prevention standpoint, continue masking, continue all of the steps of social distancing. But social distancing is not medical distancing. And so making sure that you regularly touch base with your care provider, if it's a matter of regular preventative visits as an outpatient, if it's testing that your care provider feels is the right thing for you, please follow through with those things overall. And if you're suffering from acute manifestations, perhaps related to COVID or uncertain, or you think is unrelated to COVID whatsoever, it's really important for you to seek immediate medical attention, because we've learned very quickly, not just in cardiovascular medicine, but the breadth of medicine as a whole, we've seen patients stay away from our hospitals and face unfortunate consequences as a result. And so with a timeline uncertain about a vaccine, please do not have any delays in any acute conditions, and please stay connected to your healthcare provider. Stop medical distancing, but continue social distancing overall.
Great advice from Dr. Ty Gluckman. Your health can't wait, so please take good care of yourselves. And thank you, Ty, so much for all the research that you're doing, and especially congratulations on your JAMA article that was recently published. We'll have a link to that in the chat. And I want to thank everybody for listening and tuning in with us here today. If you're looking for medical advice, please visit us online at providence.org. And make sure to follow us on social media at Providence on Twitter, and under Providence Health System on Instagram, Facebook, and LinkedIn. That's all for today. Thank you guys so much. Have a heart-healthy weekend and take care.
Stay safe, everyone.